evening for our fourth Friday Focus Seminar. And there's many of you tonight, many of you. So I'm just going to repeat. ASH Foundation stands for Aberdeen Street Health Foundation. And we are a group of 11 individuals. We're Christians and we worship at Aberdeen Street Church God of Prophecy in Winson Green. And our main focus is to support the community and the church community to maintain good health and well-being. We've done several events over the years, and at this time where coronavirus has impacted the world, we just wanted to do something and collaborate with local government and with the local NHS to look at strategies that we could apply locally and support the local church and the local community in terms of coronavirus and the apparent correlation with certain long-term conditions. And one of them is diabetes. And I'm not going to go over that too much because we're going to hear from an expert regarding diabetes shortly. And also coronary heart disease and hypertension has been implicated as well. So we'll have a session on that next week. But we really wanted to do something at a local level. Yes, there's a government investigation into the possible reasons why. There is also a disproportionate number of Black, Asian and minority ethnic individuals that have sadly passed with coronavirus. And it's just huge, and we just wanted to do something small, and hopefully that small will grow and other faith communities can collaborate with local government and the NHS to try and make an impact locally. So that's what these Friday Focus seminars are about. It's for the local community and the local church to receive information that they can use to help them to self-care during this time. And tonight we're joined by the diabetes specialist team from Birmingham Community Healthcare NHS Foundation Trust. We're going to be hearing from Dr. Waqar Malik, who's a consultant diabetologist. We also have with us Angela Thomas, who's an advanced diabetes specialist nurse. And we're also going to be hearing from Tony Kelly, who's a diabetes ambassador as well. But before I pass over to Dr. Malik, I just want to encourage you that if you haven't tuned in to the first three Friday Focus seminars, then you can catch up. God of Prophecy YouTube channel. And I do encourage you to go and look at those because there's some valuable information. So there's a lot to cover tonight, and I'm going to straight away now hand over to Dr. Waqar Malik, who's a consultant diabetologist, and he'll be sharing with us some really valuable information on COVID-19 and diabetes. Dr. Malik, over to you. Thank you.
Thank you, Bev, and thank you for ASH Foundation. I hope everybody can hear me.
I can hear you, Dr. Malik. Thank you.
Right. It gives me a great opportunity to talk to you about COVID and diabetes. I may be known to few of you because I have done few health promotions in the church over the last few years, so my face might be familiar with you. And it's all because of Beth Cunningham, because of her passion. And again, I thank her for arranging and organizing this. I would be obviously talking to you about COVID and diabetes, but I also had some firsthand experience of managing patients with severe COVID in front door, in emergency department. And I was about to fly for 2-week holidays just before the lockdown, and that obviously flights were all canceled. So I had a 2-week period. So I thought I might as well do something useful for with my 2-week holiday. So I ended up in looking after COVID patients. So some of the stuff I'm going to share with you would be regarding my personal experience as well. So Let's see if I could share. Um, right, okay, so are you able to see the slides?
Yes, we can see those. If you go to slideshow and from beginning.
Yeah, I've done that. So
Okay. At the moment, we're seeing slide sorter view. Nearly there. If you go to wonderful. That's
yeah,
it, Dr. Malik. Thank
that's
you.
it, right? Okay, good. So that's me. So I work at Birmingham Community Healthcare Foundation Trust. And what I would be talking to you would be introduction to COVID-19 with understanding of a little bit of pathogenesis, which means how this virus harms us, presentation of illness involving different body systems, the risk factors, and a bit more about diabetes as a risk, and then the medications we use for diabetes, and what we can control and what it's not in our control. So what's it not in our control, we should stop worrying about that. Angela is going to talk to you about the sick day rules, which are a very important topic, and where to look for later updates and guidelines. So let's talk about um, uh, the actual disease itself. So the virus itself is called SARS-CoV-2, which is the name of the virus, and the COVID-19 is the disease name which is given to this particular disease, which is caused by SARS-CoV-2. There are other coronaviruses. I think you may have heard them. There is Middle Eastern Respiratory Syndrome, CoV-2, which causes MERS virus, and then the original SARS virus, which was in 2003, which also happened in China. There are other 4 different coronaviruses. They cause common cold and a flu-like illness. Just imagine that we didn't have diabetes in the world. That will be the wonderful thought. And suddenly, diabetes as a disease is given to us. So the knowledge we have about diabetes is almost 100 years. You know, it's more than 100 years about diabetes. And the COVID-19 is relatively new disease. And what the virus does to us and to our body is new. And every day, every week, we learn something new about this virus and how it affects us. So there is obviously a knowledge gap. And unfortunately, this knowledge gap is exploited. This knowledge gap is exploited in the social media. So it's important for us, either we've got diabetes or not, or do not have diabetes, that we access the channels which have got some scientific basis for that. So I just need to move on to the next slide. So I'm, for some reason, can't. For some reason, I can't move on to the next slide.
Okay.
Right. Okay.
How about reversing and then going forward again?
Right. Okay. Let's do that. Yeah. Okay. So also,
There we go.
yeah, I need to remove the tab from front here. So there are some classical symptoms of which everybody knows. But before going to the symptoms, I think it's important to hear this word, which is called ACE2 receptor, because it's a lot on the social media and a lot of people have actually heard about it. ACE2 is a receptor in the nasal mucosa where the spikes of the virus itself attaches itself, and the virus itself then internalizes, it gets into the cell through that ACE2 receptor. The function of the ACE2 receptor is to do with the immune system. And what the virus does is the virus hijacks the working of that receptor so that the receptor, instead of giving protection, then starts to function against the body. And a lot what happens within our body is then the body's own response to having the attack from the virus. So the virus at that stage plays some role, but a lot of role is then played how the body itself then responds to that virus. And so the classical symptoms, for example, the virus does is that you have is a new continuous cough, fever, shortness of breath, and then the two other symptoms which have been added, which is the loss or change in normal sense of taste or smell. What it affects is mainly what we call is COVID pneumonitis. And the main problem which happens in the lungs is a very, very tiny clots which occur within the lung tissue. And it blocks the small blood vessels which prevent the oxygen getting into the body. And people, when they check their oxygen levels, they are a little bit low. The curious thing about the involvement of the lung is that the person who's got lung involvement because of the COVID have very low oxygen. But surprisingly, they have relatively less symptoms. So they can be happily talking, doing their work, not necessarily short of breath, and yet they may have low oxygen. It can also involve the central nervous system. Because of that, remember what we had is a tiny clots, but it can also predispose to larger clots. So there is increased risk of stroke. There is very curious condition which has been described. It's called COVID delirium. So patients could be quite delirious, they're changing behavior, confusion, and that can be due to COVID. Usually these extra manifestations of COVID occur in addition to what else is going on. For example, there will be very clear history of, and then there will be additional manifestations, but occasionally these extra manifestations can be predominant manifestations. And very, very rarely, they can be the only manifestation of the COVID. One of our patients, for example, who had quite severe delirium, the penny dropped quite a few days later, because every day he was saying, and in spite of being delirious, he was saying, I'm exhausted. I'm exhausted. And people are feeling that, okay, it could be just because of his delirium. He's saying, I'm exhausted. But in fact, exhaustion is one of the other symptoms patients who've got COVID, they complain. It does involve the heart. Again, relatively, it's quite rare. It can involve the heart muscle, and the technical name of that is myocarditis. there is increased incidence of having heart attacks with COVID. It can involve the gastrointestinal system, and it can cause vomiting, nausea, diarrhea, abdominal pain. So the abdominal pain, you remember what we said was a tiny clots which happens within the lung. The same thing, if you can have an abdomen, some of these abdominal pains can be quite severe. And extremely rarely, it can also involve the lining of the gut, the large gut, and can cause what we call an ischemic colitis. It does have an effect on the kidneys. The kidney failure itself, for example, is more a manifestation of towards the end of the spectrum when patients are on intensive care unit or on ventilator, and then they get the sudden surge of antibodies or cytokines, and then lead to renal failure. However, there is a protein leak which happens through the kidneys, and then that protein leak could also be responsible for some of the electrolytes, some of the abnormalities we see, like effect on the potassium and calcium and sodium. You must have seen this quite a lot recently because it was advertised. Even the BBC ran an article on this, which is the skin manifestation of COVID. And there are 5 different types of skin manifestation which has been described. The pseudo chilblain type lesions, which are seen in a young person, usually in a young person who relatively have mild disease. The other, like urticarial rash, vesicular eruptions, maculopapular rash, and livido or skin necrosis have been also described. This is just a picture of a chilblain type rash due to COVID. It can happen in hand as well. And one of the other very curious and very rare manifestation of COVID, if you can well imagine the same thing happens on the face, can give you what is called is COVID red face. This is a kind of a vesicular or macular eruptions, which you can see. One of the other, going on to the risk factors, so the risk factors are age. So we know that the person who is elderly are at greater risk, and it is perhaps to do with the ACE2 receptor. So there is greater density of receptors as we grow old. The younger people have got less ACE2 receptors in their nasal mucosa. Don't hold on to virus for very long. They hold on to virus for a short period as compared to elderly. So if you're above 65 and if you've got diabetes and if you've got high blood pressure, you hold on to virus for much longer. Men seems to do badly. There is increased prevalence of COVID-19 in men, but also men, there is increased risk of dying and risk of harm if you're a man. There are several reasons behind it. Men mix more, they mingle more, and the work they do perhaps does involve mingling with other people. I think whenever, it's very sexist remark, but whenever the personal hygiene is looked at, men have done badly. Some suggestion, immunity, we all know that women live longer than men. I think that's universal finding in every country, every nation when it's been looked at. And one of the theories about it, women have got slightly better immunity. So whenever the vaccine trials have been done, and it's quite frequent, it's not just one-off, the women respond to the vaccines much better. They generate better antibody response as compared to men. And also, women have got 2 X chromosomes, and X chromosomes are the places where the immunity genes exist. There is a lot recently in the in the lay press. That's why I'm mentioning about the androgen and estrogens, whether the estrogens in women are a little bit protective and androgens and men are not that protective. I think there was a recent evidence in person who, for example, who got prostate cancer, and some of the treatment for prostate cancer is to reduce the androgen levels of the testosterone level in the blood, and those men tend to not get harm from COVID virus. The other one, which is commonly as a risk factor, is obesity. So if somebody is overweight, obesity itself, the fat cell itself are considered to be secreting hormones and creating kind of a slow inflammation. Hypertension, diabetes, we will talk about a bit more. Asthma, people with cardiovascular disease, so COPD, they are at more risk of getting COVID-19. There is a question mark I put against vitamin D. Vitamin D, again, it's in the press. More recently, there was a very large study where they had the vitamin D levels of 5,000 patients who were already known from the UK Biobank. And then they looked at associated with the development of COVID. In that particularly large study, there doesn't appear to be any correlation with vitamin D deficiency with COVID. However, there are other small studies which suggest that vitamin D has got some role in COVID. Ethnicity is I think you know, you've all heard in the stories, and some of these difference in ethnicities are shocking. So, for example, in Chicago, almost 75% of deaths happen in Afro-Caribbean people with Caribbean background. The data which is been available, and some of the data would suggest that generally are 3 times or even more than 3 times either likely to get or get to harm with COVID-19. Reason for that is probably multifactorial, so some of these actual real reasons needing to work. Some of it could be the demographics, but some of it could be related to some genetic differences. So what I'm going to share with you is this one. This was actually an evidence which was just shared this week. And it's one of the largest study you can well imagine. So that's based on the almost 61 million people in UK. And then what I want you to do is a lot of words there, but I just want you to concentrate on the last 2 numbers, which are in red. So if you've got type 1 diabetes, and if every other aspect other than obesity is taken care of, with type 1 diabetes has got 2.86-fold increased risk of dying. And if you've got type 2 diabetes, then that risk is 1.81-fold. This is a more graphic presentation of so what happens, and it's been divided with different ages. So the one at the bottom is looking at the person who doesn't have diabetes. So you can see that with the age, the mortality or the risk of dying increase. The blue one is if you've got type 2 diabetes. So you can see the clear difference, but the risk, again, the difference is with increases with age. And also on the top, on the red one, is type 1 diabetes. And this is, again, this is one of the Chinese, again, this is not a peer-reviewed, but it's available online, because a lot of this information becomes available and the journals and the medical journals put that out without going through the normal peer review processes, because they feel that it's in the public interest for this information to be available. So this is not a peer-reviewed study, but it was a very large study from China, which is about 7,778 patients, and they were looking at the risk of death, and then they divided the patients if they had a well-controlled blood glucose, and they the red glucose is if your blood sugars are less than 10, and if your blood sugars are more than 10. And you can see if the blood sugars are less than 10, then the survival is 98.9%. And if somebody is blood sugars are high, then the risk of death is 11%. So this information is not new, because we knew if patients, for example, are admitted to an intensive care unit for whatever reason, and if they're admitted with a high blood sugar, then the outcome is not very good. Same applies to a person who is admitted to a hospital with, for example, heart attack without COVID. And if they're admitted to hospital with high blood sugars, they tend not to do very well. So what can you do if you've got diabetes? What you make sure that you've got enough supply, and at least enough supply means that you've got at least all the time 1 month supply of all the medicine. If you're checking your blood sugars, then you should have access to a month's supply of blood testing strips and lenses. And if you happen to check, if you've been advised to check your ketones, then you have a ketone testing equipment. Just make sure that the ketones tests are up to date. So if, for example, somebody does have COVID, then they are encouraged to test more frequent testing. If you do not have access to blood glucose monitoring, then look for symptoms for high blood glucose. They include thirst, passing more urine, unusual tiredness, and then you need to seek medical advice if you have any of those symptoms, if you've got diabetes. Angela is going to talk about this a little bit more detail. These are symptoms of so if you so that's what you do is you take rest, and then you take some sugar if you can't take your normal food. Again, Angela will go through that a little bit more detail. And drink plenty of fluids, obviously, because if you've got high temperature, you do get dehydrated. You treat symptoms of high temperature, such as taking painkillers. There was some concerns about the non-steroidal agents, such as ibuprofen and other drugs or Voltaren type drugs. And it's advisable that you avoid taking non-steroidal as painkillers or to relieve your symptoms. And then what you need to do is you need to see your GP, monitor your blood glucose, adjust your diabetes, and seek medical help.
Dr. Malik?
Yep.
Dr. Malik, fantastic. I'm just giving you a time check. You 10 minutes left. Could I also ask, please, that could you mute your mic and then unmute your mic? There's a few individuals that are having problems hearing you, and this might help. So if you mute your mic and then unmute your mic, please. Thank you.
Okay. Okay, can you hear me better now?
Sounds good, actually.
Right, okay, good. So yeah, so these are the symptoms of diabetes, uncontrolled diabetes. Some of these you may, some of them are related to type 1 diabetes. So people are more thirsty, the blood sugars go high, the abdominal pain, stomach pain, which is because of the high ketones in the blood. And then there's a ketone smell in the breath as well. And the drowsiness, for example, is kind of you don't want to get there. You need to seek help before drowsiness starts. For some reason, I've lost, now I can't actually move it forward.
Try reversing again and go forward.
Yeah. Shall I? Shall I just pause share and then resume share? Right, okay. Okay, right. So this is taken from a practical recommendation. Can everybody hear me? Okay.
You can, Dr. Malik. Thank you.
Okay, so this is taken from practical recommendation from international consensus regarding, and I'll just concentrate on the outpatient management. So obviously you need to make sure that sensitization of patients with diabetes for the importance of optimal metabolic control. They need to have a good blood sugar control, and they need to optimize their current treatment if appropriate. And there is a caution about premature discontinuation of established treatment. So patients who are already on existing treatment and they don't have COVID, then they shouldn't stop their existing treatment. And then what this consensus also encourages utilization of telemedicine and connected health models, care models to maintain maximal self-care. They do talk about control, which control itself appears to be quite ambitious. So this is ideal blood glucose concentration between 4 to 8, the HbA1c, which is the test for long-term diabetes control. And there is a little bit about continuous blood glucose monitoring and the hypoglycemia. So trying to avoid hypoglycemia in patients. So okay, so just very quickly going to the medication. So the medication, if you talk about metformin, so metformin, what we're talking about now is somebody who's got COVID. It doesn't apply to if somebody doesn't have COVID-19. So if somebody does have COVID-19, then the dehydration can lead to increase in the lactic acid. Also patients, for example, who got low oxygen, which is called hypoxia, that also leads to lactic acid. And also during the acute illness, if somebody is vomiting and have got sweating, then that can lead to fluid loss, and they may have a degree of renal impairment, may not be very good. So that can lead to lactic acid. And because of that reason, if any of those situations arise, then it is recommended that the metformin is suspended. And that applies to even in the non-COVID situation. The other tablets are called sodium glucose co-transporter inhibitor or SGLT2 inhibitors. So these include canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. So the trade names are Invokana, Forxiga, and Jardiance. So if somebody is taking and somebody does have COVID, then it's advisable that they should suspend these medication. And the reason is because we know that these medications have got a risk of developing what we call is diabetic ketoacidosis. It's a very rare complications, but because of COVID, and there is some concern that the COVID may lead to slight high ketones in the blood anyway, then it's advisable that during, if somebody does suspect that they may have COVID, then these medications should be suspended. Sulfonylureas, which in our cases mainly contain glycoside and glimepiride. And if somebody is unable to eat or drink, these medications can drop the blood sugars too low. So, and also it's advisable to test the blood and then stop sulfonylureas. However, if eating and drinking normally, then it would be reasonable to continue taking these medication. GLP-1, glucagon, which some of our patients take. So these are the injections either taken on a daily basis. There's not insulin. It's a different way of treating diabetes. So these are called dulaglutide, which is Trulicity, prolonged release exenatide, which is called Bydureon, liraglutide, which is Victoza, lixisenatide, Luxturna, and glutide, which is Ozempic. So if somebody is taking, and if somebody does have side effects from that, such as quite severe vomiting, and then it can potentially lead to dehydration. And patients are encouraged to drink plenty of fluid when they're taking this and take a regular meal. DPP-4 inhibitors, which are the other medications which are used, which are alogliptin, linagliptin, saxagliptin, sitagliptin, and they are well tolerated, and one can continue. The insulin itself should not be stopped. Obviously, as we said earlier on, there is more frequent monitoring of blood glucose is needed, and then there is careful adjustment which is needed during COVID. This is very important because you did mention, we've already talked about the metformin and SGLT2 inhibitors. If somebody does have COVID, then they need to be stopped. The question is, what do you do? Because if somebody's already blood sugars are running a little bit high, and just already stop your existing medication, that the blood sugars will go further high. So it is very important that when you're contacting 111, so somebody's got diabetes, you do mention that you may have to discontinue some of your tablets, and then it may be that if you've got diabetes and your sugar is not satisfactory and you've got COVID, that you may need to go into hospital. And I would make this opportunity to urge that the hospitals have got plenty of space at the moment. So there's no harm in seeking help and going into hospital, because we've had cases where people have spent too much time in hospital, very reluctant to go into hospital and come to harm. And also, when you speak with 111, like all of us, 111 is also learning. And so they would take, for example, hyperglycemia or high blood sugars as one of the factors which may require you to be admitted to hospital. So what about the other medications? So one of the issues which you remember, we talked about the ACE2 receptor where the virus attaches itself. So a lot of people then got confused because one of the medications which is used to treat high blood pressure and heart conditions, they are ACE inhibitors. So ACE inhibitors and angiotensin converting enzyme, which is the medications, they tend not to, the patients who are taking those tend not to get into any harm. The other group of tablets which they take is called statins, for example, and the statins theoretically seems to have some beneficial effect. So continue ARBs and continue statins. And also we did talk about the delivery. So make sure that the patients have got access, and then telemedicine and self, and especially management is important. There is a bit about a frequently asked question. So this is about should people with diabetes be shielding? At the moment, there is no universal advice about diabetes that they should shield. But as I shared with you, that new evidence about diabetes has come to light recently, and that evidence has been put forward to NHS England and see whether they would come up with a different strategy. Diabetes. I'm high risk. What can I do? But this is very important. So I don't have that much. I've only got 5 minutes. Okay. So I hope you will bear with me with 5 minutes. So there are a lot of, you don't have.
Okay. Sorry, Dr. Malik. It's fine to carry on.
Yeah. So there are certain things which you can't control. And one of them is you can't control your age, the age you're in. So if increasing age puts you at high risk of developing COVID or getting from COVID, you don't have any control on it. And so is your ethnicity. So your ethnicity is not in your control. You can't control what other people feel, what their opinion are. You can't control feeling more vulnerable, because you've just heard person with diabetes is at a high risk of coming to harm from getting COVID. You can't control the scare stories in the media. It's not under control, and people will do that. Some of that scare stories are 4 or 3 M, so it's misguided, misinformed, some of them malicious, and some of them are manic. So these scare stories are there. It's not under your control. Control who catches it, or will I catch it if you do all the things you're told to do, wash your hands and look after yourself, and then don't go out, don't mix, self-isolate, then will I catch it? That's not under your control. It's getting canceled. Your appointment's getting canceled, casing happening close to me. Again, you can't control it. Availability of healthcare professional and appointments. There's a lot of you feel that you can't see them face to face, and you can't get an appointment when you really want it. This is not in your control. It's in the shops, again, not under your control. Needing to self-isolate if symptomatic, if you do happen to have COVID and you need to self-isolate, again, it's not in your control. So it's important that you keep social distancing measures, and that you can do that. You do regular blood sugar checks. You do make small changes at a time, and then stick with those changes, consolidate those changes. So let's just see if we could move this again. Right, okay, I need to then pause, and then let's see if I could go back now. Okay, so take your insulin and prescribe medication regularly. Reach and maintain recommended healthy exercise and healthy weight. I think one of the things we have done recently, a lot of telephone consultation, because that's what we do. Patients have actually shared their anxiety about weight gain. They've gained a few kilos and a few pounds in weight. And it is important that you continue your exercise. So you're allowed to exercise and go out and exercise. take the time to refresh your memory and update your knowledge about sick day rules. So again, you need to then listen to Angela. Ketone strips at home, keep them up to date, keep treatment at home, ensure members of your family know how to help you in events of low blood glucose. Use wider platform available for you to help you manage your diabetes. Get onto people or platforms you know and you trust. Continue to check your feet on a daily basis. Continue to attend your routine screening if and when it becomes available. At the moment, it may not be available. When it become available, you do attend that. I think some of you may have already attended self-management programs such as our TILT course or expert diabetes program, or in case of type 1 diabetes, DEFNI program. And some of the books and the literature which was given to you may be collecting dust, so it's time to have a look at them and refresh your knowledge about your own diabetes. So this lockdown has also resulted in people acquiring new skills. And one of the skills which have been very popular is cooking. So Diabetes UK is there for person with diabetes, but one of the good thing about Diabetes UK, there are many good things, but one of the good things is that if you Google Diabetes UK and meal planning, you can access these lists of different meals which you can try it at home. So for example, if you want to try a Mediterranean meal planner, so when you click onto the Mediterranean meal planner, it will take you to your weekly medication. So weekly medication, so for example, weekly meal. So for example, on Monday, you could have this breakfast, lunch, and dinner. And when you click onto the individual, for example, meals, it will take you to how to actually cook that individual meal. So it will have a recipe. And not only it will have a recipe, the recipe will contain that each recipe contains that much carbohydrate, that much calories, that much protein. So it's a very, if you want to practice and develop skills, want to develop healthy eating, I would strongly recommend that you go onto Diabetes UK website and look at the meal planner. At the bottom, there were other two meal planners, and one of them was a budget. So if somebody is on a very low budget, there is a meal planner for a low budget cooking as well. So these are some of the other websites, and I will leave it. These slides will be available with Bev, so she can leave it with you. Angela will be sharing some of it as well. So there is some direct telephone helpline as well. So UK helpline, which is available from 9 to 6. And NHS England helpline. If you've got a clinical concern and you want to talk to the NHS England directly, there is a telephone helpline for clinical queries available as well. I would also recommend this, if somebody is on Twitter, they can go to this Twitter feed, which is from Team Diabetes 101. So, and they have actually just very recently done a PDF on a lot of basic questions where patients, a person with diabetes may be interested in. About staying at home.
Sorry, Dr. Malik. Sorry, Dr. Malik, you are cutting in and out there. Do you want to, would you like to mute and then unmute again for us, please?
Right, okay. So, okay, so is that better now?
Yeah, there's some improvement, thank you.
So then this has got a lot of questions and answers. So just remember, you can go to Team Diabetes 101 on Twitter. And this is being run by the diabetes consultants, dietitians, by psychologists. So everybody who's interested in diabetes, they've given their time to this. So one of the consultants even works for Department of Health. So what you will get is very up to date and very rapid access to information. And they do actually, you can ask questions on Twitter as well if you're interested. And I think that's probably my last slide. Let me just see if I could again. Yeah. So that's me.
Is that your last slide?
Yeah, apologies for running over a little bit. Yeah, but
That's absolutely fine. We will catch up.
yeah.
So thank you so much for that, Dr. Malik. If you would stop sharing your screen for us, please. Thank you. Okay, if you could unshare your screen for us, Dr. Malik. While you're doing that, that was wonderful presentation. Thank you. And there are quite a lot of questions, which we will get to at the end, towards the end. The next section that we're going to be covering, thank you, we were going to move to Angela Thomas, Advanced Diabetes Specialist Nurse, to discuss issues around sick day rules, what you do if you're poorly, etc. But there's quite a few questions around that topic. So we're going to pick up on Angela's talk during the question and answer section. So I'm going to move on to a short interview with a diabetes ambassador, Mr. Tony Kelly. I don't know, technicians, if we're able to do a joint screen with myself and Tony Kelly. I don't know. But Tony, can you hear me?
Hear you. Can you hear me?
I can hear you fine. You're a little bit low. I don't know if you want to come a bit closer to your device.
Yes, I'll come closer.
Oh, that's much better. Thank you very much for joining us. So, Tony Kelly,
Thank you, Beverly.
You are known to quite a few of us, but let me just pick out a few points from your bio that you sent me. So, Tony has done a lot of work with Diabetes UK, around 8 years. Tony also has type 2 diabetes, and you are now a diabetes ambassador, and you have got a, how can I put it, a passion with capital letters for diabetes, haven't you, Tony? Absolutely, very passionate about the subject. And
Thank you.
You do speak at many health events, health promotion events.
Indeed,
and
indeed.
You also work with the clinical commissioning group, Birmingham and Solihull Clinical Commissioning Group as well, don't you, Tony?
That's correct. That's correct.
So that's absolutely
Dr.
fantastic.
Richard Mendelson and his team.
Sorry, would you like to repeat that? Sorry.
I say it's Dr. Richard Mendelson and his team at the Clinical Commissioning Group,
Wonderful.
Birmingham, NHS,
Thank
and
you.
Solihull.
So I thought we'd just do a little interview with you, if that's okay. I've got 3 questions that I would like to ask you. So first of all, so we've got 202 participants, 203 now actually, so that's absolutely wonderful. So firstly, Tony, could you tell us a little bit about your journey of living with type 2 diabetes, and how do you maintain your control?
Right. First of all, Beverly, so that the listeners and viewers know, I'm British born, but at an early age, my parents sent me off to the land of their birth, which is Jamaica. So I grew up in Jamaica. As a child growing up, age 7, 8, 9, 10, I noticed relatives of mine who were starting from the head, had strokes, some were blind, some had heart attacks, Some had to go into Kingston for kidney dialysis due to renal failure. Some had lower limb amputations. And of course, some died prematurely, or we in Jamaica would say, gone too soon. And I would ask, very inquisitive mind, inquiring mind, what's the matter with Granny or this person or that relative or whoever? And I was told, they have a touch of sugar. So this medical condition, diabetes, in the Caribbean and some African and some South Asian countries, is referred to as a touch of sugar. So it's minimized and trivialized and downplayed. Fast forward, I came back to the land of my birth in 1979, and I've lived in Birmingham ever since. I was a teacher in Jamaica, high school teacher. And 16 years ago, December gone, I developed the 4 key symptoms, the 4 classic symptoms that I might have type 2 diabetes. Bearing in mind, it's hereditary, it runs in my family. They're called the 4 T's. T for tired, T for toilet, T for thirsty, and T for thinner. I was displaying all those 4, and typical of men, like the ostrich, burying one's head in the sand. My wife kept saying, something's wrong with me, something's wrong with me. But men are into denial. We don't own up to ever wanting to say something's wrong with us. Eventually, I plucked up courage, went to my GP. For those listening from abroad, that's my family doctor. And she put the dipstick in, a sample of my urine, early morning urine, and it showed I had type 2 diabetes. I had glucose or sugar, same thing, in my urine. But for a final analysis, she sent off a sample of blood. And it came back, an early Christmas present, 16 years ago, I have type 2 diabetes. I decided to make the lifestyle changes. And I know Dr. Malik has spoken a lot about the clinical and the medical. I have had this medical condition for 16 years. I have never taken medication, no pills, no tablets, no insulin, no metformin. It is by leading a very, very healthy lifestyle I have managed to keep the complications I alluded to at bay. And you can ask me, what do I do?
So that's...
I know we're in lockdown, but I do a lot of physical activity. I despise, I detest, I hate the word exercise. Exercise conjures up images that you're being asked to go to the gym, put on your lycra shorts and go to the gym. Physical activity, gardening, hoovering, mowing the lawn, climbing the stairs, line dancing, those are things which we need to be doing more, leading a more active, physically active lifestyle, more movement, instead of sitting down like the couch potato or the sedentary, sit on our posterior lifestyle. It's about movement, it's about getting up and doing things, letting the heart
So Tony,
yes?
can I interject? Because we know each other, don't we, Tony? And you know that I have to interject now and again, don't I?
Yes, indeed, when I start.
Because like I said, you are passionate with capital letters. So,
yes.
So can I just say something for the audience as well? You said that you were diagnosed when they dipsticked your urine, okay? Let's just be clear. Let's just be clear. Yes, that's a way of dipsticking urine, maybe monitoring your diabetes, and it could be an initial indicator that something is wrong.
Yeah.
If anybody
yes.
has had a dipstick at the GP, general practitioner, then that will be followed up by a blood test, test from the arm within a puncture. I just wanted to clarify that, okay? And Tony, can I just ask you a second question then?
Yeah, go on.
So, okay, so we've got somebody who's newly diagnosed with type 2 diabetes then. Very succinctly, what would be your 3 top tips for that individual? Very succinctly.
Physical activity is number 1. They need to do more physical activity. They need to develop a healthy, well-balanced diet, which includes a lot of fresh fruits and vegetables, no fry-ups. They need to boil, steam, grill, roast, or bake, cut out on all the fry-ups. And also, I must impress upon them carbohydrates. Some people think, well, I have diabetes, I'm going to cut down on sugar. All carbohydrates, which is starchy food, breaks down into the digestive system into glucose or sugar. So you need to be mindful of your carbohydrate consumption. And it's about the behavioral changes. It's about the overall lifestyle changes. It's about being more active, eating the right things and cutting out sort of the comfort eating and the fast food and so on. That's so important. And this is what I do in order. People call me Mr. Motivator II. For those of you who know about British television, there was a green goddess on BBC, Diane, and there was Mr. Motivator who went to live in Jamaica. He had the different colored socks. I don't have those, and I don't have the light one. But I am passionate about going into elderly people's homes, residential homes, churches, mosques, and saying to people, more physical activity, more movement, get up and move. One of the things which has gone bad for all of us is the remote control on the television. People, hide the remote control. And if you have to turn or switch the channel 4 or 5 times within an hour, get up from your seat and go and do that. When you go to the supermarket, don't use a travelator, use the stairs. When you're in a high-rise building, if you're able to and you're mobile, use the steps. Don't use the lift or the escalator or the elevator. Park the car. When we were growing up in the Caribbean, most of us didn't have a car. So why do people have to drive the car 500 yards down the road to get their morning paper and their bread? We need to walk more. We need to do more physical activity. And that's what I'm about. And that's what I do in the education events that I do up and down the country.
Fantastic. Is this your last tip, Tony?
Sorry?
Is this your last tip?
All right. You've also spoken about people who have diabetes. There's 1 million people estimated within Britain who possibly have diabetes but have never been diagnosed. So my advice is you need to go to your GP, your family doctor. There are a lot of courses, the clinical commissioning group that I'm involved in. It's a national diabetes prevention program for people who are in the pre-diabetes or borderline stage, who need to do something about losing the weight, especially around the midriff. And you need to be mindful, it's not only people who are overweight, obese, who can develop diabetes. People who are of an average or slim weight can also develop it. And I am available, as you know, for talks anyway. Tony Kelly Diabetes at hotmail.com. People can get in touch with me.
Tony, thank you so much. I did have 3 questions, but you've covered them. You've covered the 3rd question in the first 2 questions, okay? And that's absolutely fantastic.
Okay,
and you know, your passion is rubbing off on the audience. I can tell by the comments on the chat. And we will have to get you back. Okay. We will have to get you back for another occasion. I really want to
because I've been doing it for 8 years. 8 years out there doing this in communities.
Fantastic.
Here
fantastic.
and abroad.
Absolutely fantastic. I really want to give time for the questions. So
that's fine.
It's been great so far. It's been really, really engaging. Thank you, Dr. Malik. Thank you, Tony. And I will now need to pass to Doreen and Pastor Donna to go through the questions that have come in on the chat. And this is where Angela Thomas will also come in and give some of the answers. Can I pass over to you, Ash Foundation colleagues?
You certainly can, Bev. Thank you.
Thank you.
Good evening, everyone. It's good to see so many of you joining us this evening, and we're grateful to our previous speakers. We do have a number of questions, and so if I begin, Doreen, and then do you want to follow?
That's fine.
Okay, great. So our first question, one of our listeners says, I watched an online video recently about diabetes. The presenter, a doctor, said that treating diabetics with insulin is like treating an alcoholic with alcohol. What are your thoughts? That can be to Dr. Malik.
Right, okay, so it is, it's probably not true. What happens, so we're talking about, for example, type 1 diabetes. So type 1 diabetes, the insulin is needed for survival. You know, in old days, the only way you would know if somebody's got type 1 diabetes or type 2 diabetes is that if you don't give somebody insulin, they live, they would have type 2 diabetes. And if they die, they have got type 1 diabetes. If they die, they have type 1 diabetes. If they live, they have type 2 diabetes. So type 1, for type 1 person who's got type 1 diabetes, insulin treatment is a question of survival. Now, if you then go to type 2 diabetes, during the initial phase, there is increased insulin production because the body wants to fight off the resistance to insulin. And that's a lot of that is related to being overweight. But with the passage of time, the body then produces less insulin. And then when the insulin, when the cells in the body, the pancreas in the body, then start to produce less insulin, then yes, people, even for type 1 diabetes, for type 2 diabetes, also need insulin for diabetes. Now, person who's got type 2 diabetes, they can do a lot of things which Tony suggested. You know, if they then change the way they live their life, it is perfectly possible that they may not then need the insulin treatment.
Thank you. Thank you for that. And so if we move on.
So with the issue, but yeah.
Yeah, you completed? Right. Is there a difference with COVID reaction to type 1 and type 2 diabetes?
So it is again a rapid
Dr. Malik, your audio.
Yeah.
Could you just mute and unmute, please?
Right. Okay. So is that better now?
Thank you.
Yeah. So ACE2 receptors are also available, are present on the beta cell, the cells which produce insulin. So there is some evidence that there is some deterioration in diabetes control in certain people, not everybody, in some people with diabetes, and that is roughly the same. The other, specifically, we've seen in diabetes that there does appear to be increase in the ketone production. So there is more ketones in the body. And both of them are roughly the same. So people, for example, even type 2 diabetes, sometimes they can have increased ketone formation temporarily while they've got. Between type 1 and the response, it's roughly increased need of insulin, for example, and also increased ketone formation for type 1 diabetes, but also for certain type 2 diabetes. And the other difference we looked at it was I shared the data about the death in, so there appears to be increased harm in person with type 1 diabetes.
Okay, thank you. You mentioned a large population based on a new UK study with 61 million people. Somebody's asking, what is the name of the large population?
So the large population is a registered people. So these are people who are registered. So I think the UK population is or the population which they can access. So this is an adult population. So it's excluding children. So I think the UK population is about 68 million. So it is including everybody other than children in that study.
Thank you.
Could I interject, Pastor Donna? Dr. Malik, would you pass the title of that document to me, and I can get that on our
yeah, I can. Yeah, so it's a large PDF. So yes, I would be quite happy to share that.
Thank you.
Thank you. Does sickle cell disease with diabetes increase your risk of getting COVID-19?
There is as such. So for example, I did mention to you about the study about the persistence of the virus. So there is some studies. So with increasing age, and if you've got high blood pressure and you've got diabetes, you tend to hold on to the virus for a little bit longer. So whether that is one of the reasons why people may get into more harm, or whether they may have, because the diabetes, unfortunately, or especially type about, doesn't come on its own. So person who's got diabetes is more likely to be on a heavy side. It's more likely to have high blood pressure. So, and then high blood pressure and being overweight carries its own risk of catching. So yes, if you combine these three, person with diabetes would be at increased risk of catching COVID.
Okay, thank you. My final question before passing over to Doreen: why is it important to check your feet?
Yeah, so one of the things which has been neglected, because you would get annual feet checkup, and then with the current situation, you are not having your annual feet checkup. So the best you can do is to do self-examination. So the self-examination, you can use a mirror to look at your soles, and then also look for hard skin, look for any evidence of any skin discoloration. But also the person who's got diabetes could have effect of diabetes on the nerves. So they may have problem with their feet, and they may not necessarily know that something is going wrong with their feet. So daily examination is part of what we recommend to person with diabetes anyway. But in the current environment, when they're not having their feet checked up, it is much more important that they actually do that examination themselves.
Okay, thank you very much. Over to Doreen.
Okay, I've just got a few more questions. I'll start with the first one. So, how do I manage if my blood sugars go too low?
Sorry, could you
How
repeat
do I
that?
manage if my blood sugars go too low?
Right, okay. I think I'll pass it on to Angela. So, Angela, would you like to take this question? Yeah, Bev, would you like to bring Angela in?
Yes, can you see me? Can you hear me? Can you hear me?
A bit louder, Ange, please.
Oh, can you hear me?
That's better if you say, yeah. That's
Yeah.
better.
So low blood glucose is what we call hypoglycemia, or hypo for short. And what you may experience is symptoms such as shaky, sweating, feeling just generally unwell. So we always recommend that you check your blood glucose levels. And if it's less than 4, that's when it's too low. So what we would suggest then is you have what we call rapid acting glucose. So that would be orange juice, which we recommend around 200 mils. Can you hear me?
Yes, we can still. If you can sort of raise your voice a little bit, that would be great.
Okay. Can you hear me now?
That's a bit better.
Thank you.
A bit better.
Okay. So the treatment for hypoglycemia would be orange juice, 200 mils, Lucozade, the original Lucozade, and we normally say take around 220 mils, or dextrose sweets, what you can purchase in the shops, the chemist, and you need to take 5 to 6 of those to treat a hypo. Or you can have just normal Coca-Cola around 150 mils. But it's very important, once you've treated the hypo, then, oh, I'm saying that you can't hear me still? Okay. Once you've treated the hypo with the rapid acting glucose, then it's very important that you then check your blood glucose levels to make sure that it's come up above 4 millimoles per litre. And then to follow that up with what we call a slow release carbohydrate. So that can be a glass of milk, or a slice of bread, or if it's your meal time, you can have your meal. I think they're still struggling to hear me.
Thank you, Angela. I'm going to move on to the next question, and that is, it's a general question that somebody's asked. So, what can be recommended for diabetics to do as the lockdown eases?
Okay.
So, don't know who wants to answer that one.
Sorry, so the question was that what should we do if the lockdown eases?
Yeah, so what can be recommended for diabetics to do as the lockdown eases?
I think they just need to follow their normal routine. So whatever is allowed and one of the things is that they need to be more active. I think, as I said, a lot of feedback we've got from the person with diabetes is that their concerns about the weight increase. So I want them to be a bit more active. They can still be more active. But when the lockdown eases, they need to be. The other thing is they need to, because they're at high risk, they need to practice the hygiene measures much more robustly. I think we've got examples. For example, I don't know whether the face mask itself, whether they should be the person with diabetes more likely. It's always questionable about the use of face mask in public to prevent yourself. People say it's more to prevent other people getting it. There may be a little bit of protection. So I think if somebody is protected a little bit by using face masks, especially if they're going into the crowded areas such as public transport or shopping, I would encourage. But all the hand washing and sanitization of the hand, I would encourage them to use that.
Well, thank you very much.
Could I interject there? Could I interject on that answer as well? It obviously depends on the individual as well, but I would also arrange to see your GP practice nurse or your diabetes specialist team. There might be many individuals with type 2 diabetes that have not got the facilities to self-monitor their blood glucose at home. So if you had your annual review way before lockdown and you were due an annual review around lockdown and you've been self-isolating depending on your age, then you need to get to see your diabetes team or your practice nurse or GP to have your diabetes bloods done, especially your HbA1c and your kidney function as well, etc. Because we need to find out what your control is like, what it's been like throughout lockdown as well, because being more sedentary, not being able to go out and walk as you normally would, maybe you're in the house and you are eating more foods, different type of foods than you normally would, more than likely some individuals' HbA1c may start to creep up. So you'll need support to actually come up with a plan, individualized plan for you to try and get your control back where you'd like it to be. Thank you.
Thank you, Bev.
Thank you. I'm just going to ask one more question. We've got quite a few more, but we don't have time to ask all of them. But as far as possible, we'll put answers on our website. So my last question is quite a specific one from somebody, and it's: my GP does not give blood testing equipment unless you're on insulin. So I bought my own, but I can't get the test strips. What should I do?
Yeah, locally there is guidance on blood testing, but also the National Institute of Clinical Excellence, they've also put forward their guidance on the testing. So a person, for example, who is on medication, which is likely to cause hypoglycemia, so it's not only insulin, but some of the other medications as well, such as gliclazide, which can potentially drop the blood sugars too low. And also the NICE, which is National Institute of Clinical Excellence, also recommend that the person if they are experiencing hypoglycemia, then they need to be tested. If somebody's blood sugars are high and they've got an intercurrent illness, and then their blood glucose needs monitoring, the NICE also allows for a short-term monitoring. Now, the NICE guidance as such has not been then incorporated into the local guidelines, But if somebody is taking the medication,
Sorry, Dr. Malik, your audio.
There be a room to, if the GP doesn't prescribe, then it's all we can do is, the person can do a limited by themselves and do a limited testing. But so the local health economy does have their local guidelines. We may not necessarily agree with those guidelines, but these are the guidelines which exist. But within that guideline, there is a room if the GP wants to use the NICE guidance as a way of prescribing.
Okay, thank you very much for that. We do appreciate you coming to us, and thank you also for the other participants as well. Your talk, you honed in on some of the other manifestations, like involvement of the nervous system and the gut and the heart muscle. And it was really interesting learning that many of us may not have known that those systems could be involved as well. And I also liked the way that you focused on self-help and what diabetics can do to help themselves. So thank you so much for coming and speaking to us. Thank you also, Angela, and thank you very much, Tony, and we really appreciate your time. Thank you. I'm going to hand back over now, Bev, to you.
Okay, thank you, Doreen.
Bev, can I just ask one final question, which I think is quite an important question that we've missed?
Can indeed. Yes, you can.
Thank you. In specific terms, what is the connection between COVID-19 and the high occurrence of death in the mortality rate of ethnic minorities with diabetes? Dr. Malik.
Yeah, I think it's a very tough question to answer, and I think it is probably multifactorial or multiple factors. So if, for example, you look at, if you look at, for example, poverty, deprivation, that on its own is a risk factor for harm. If you look at, for example, the other suggestion, for example, is people with ethnic background, maybe the household numbers, maybe more living in a house, so more likely to catch. They also, obesity, for example, will play. So one of the, and it probably doesn't apply to Afro-Caribbean, because Afro-Caribbean, they may be a little bit overweight, but most of the weight in Afro-Caribbean is muscle, it's less fat. So, but one of the things which is very curious about the fat itself is that, for example, in Asians, they may carry, so if you take the same BMI, say for example, 30 in a white person and an Asian person, and if you measure their body fat, so an Asian person will carry more fat in their body. And some of this fat is what we call is metabolically active. In other words, it causes slow inflammation. So if you remember what we talked about, the virus itself, because virus then hijacks the normal function of the body. And then also some of the changes, especially that microclot formation, which we talk about in the blood vessel, is a response, if you can call it, it's an inflammatory response. So people who have got ethnicity background, they may carry a little bit more fat, there may be some demographic changes, but I think a lot of that may be related to some different genetic predisposition. So for example, we know that the people with Afro-Caribbean background, they respond to blood pressure treatment differently. So for example, they respond to calcium channel blocker, which is a different type of blood pressure treatment, better as compared to, for example, ACE inhibitors. So there may be some genetic differences which we are yet to define, but I think there will be more work, and I think there will be attempt at a very high level try to come up with an answers. At the moment, we do not have all the answers, but it is very, very striking difference, and especially in people with Afro-Caribbean background, it is far striking.
Thank you, Bev.
Thank you, Pastor Donna. Thank you, Dr. Malik. Thank you to all of the 190 that are still in attendance, and however many that are on YouTube. We could continue, I'm sure we could continue, but I really need to hand over to Bishop Paul McCullough, who is going to give a vote of thanks and close us out in prayer. And then, if Pastor Paul, if you could come back to me very quickly at the end, please. Thank you very much. Over to Bishop Paul.
Thank you. I just want to echo the vote of thanks and appreciation that has been expressed by both Doreen and Bev. And to all those who joined us tonight, fantastic. I think it was great that so many people joined. But we especially want to thank our guest speakers for taking time to be with us tonight to share on this very important topic. To Dr. Malik, to Angela and Tony, thank you so much. It's been very informative. And as we can see from the comments in the chat, that people have found it very, very informative. So we want to say thank you so much for your time. We appreciate you taking the time to be with us this evening. We also want to thank our team, our ASH team, Sister Bev and the team. We want to thank you so much for this initiative and for the time and effort that you put into it to make this possible. And also those behind the scenes hosting and trying to deal with all the technical issues. We have to, at some point, lay hands on these devices so they can perform as they're meant to. But we want to thank you so much. I understand that someone from Bristol, a consultant pediatrician, has joined us from Bristol. I'm not sure who that is, but we want to thank you for being with us this evening. And so, of course, your comments, you're putting your comments in the chat, and continue to do that. Your feedback, that's very useful for us to know. And so I want to just to close. This has been a fantastic session, and it's so important. Our health is so important. So many of our people are suffering in this area, and the information we hope will be beneficial to us, and that we will at least try to apply the disciplines that has been mentioned. And sometimes it's about discipline and or the lack of discipline. So if we can just do that, I think it'll do us great, give us great help. So let me just pray as we close out, and then I come back to Sister Bev. Just bow your heads with me as we pray. Heavenly Father, we thank you for just being with us tonight. We thank you for all those who have joined us, Lord. And thank you for our guest speakers and those who have shared their knowledge and their experience with us tonight. Lord, we pray that you'll just be with them as they continue to share the information that can be of benefit to our health and well-being. May you be with them. May you strengthen them. May you keep them in your love and mercy. Lord, we thank you for all who have joined us tonight. May your blessings be upon us, Lord. And as we try to stay healthy, I pray that you will just help us, Lord, and give us the strength and the determination, oh God, to apply the discipline that is necessary in our eating, in our lifestyle, oh God, that we might be able to be healthy. And so, Father, we thank you. Be with us as we continue the sessions over the coming weeks. May you be with us, that everything will go well. We commend everything into your hand. In the name of Jesus Christ, our Lord. Amen.